So we are struggling in terms of finding transportation routes, as everyone can imagine, as we all see these airports closed down. Similar things are happening at ports in many countries where ARVs are going to. And so we have encouraged all of our staff to share with ministry counterparts the WHO request. There's a letter that was sent out on March 30th. This is just highlight content. But essentially, we really do need our Ministry of Health counterparts to work closely with other colleagues within host governments to allow for an opening of transport of goods. And this is true for not just our ARVs, but broader emergency response for COVID. We can go to the next slide. Really specifically, the US government has been, as Miriam said, on multi-month, but really around placing orders, we've been thinking about putting in all ARV orders immediately through the end of the calendar year. In fact, it was just updated yesterday to go over, and those are fully financed. And then we've asked countries that use US government assistance to buy ARVs to also include their orders through the next US government fiscal year, so through September 2021, so that it's a clear signal of demand to manufacturers and we can begin to really parse out with other global suppliers, such as how to even out the supply. So we also have adjusted for longer lead times. The advice so far has been to at least order 1 month earlier than one normally would, but I think that's going to continue to evolve, and we'll know more when India decides next week what the lockdown status will continue there. And we are preparing to have to pay more for logistics. So we can also say that, before I dive into multi-month, just that we recognize that there's an additional cost to that freight and that some budgets are not going to be able to accommodate that. So that combined with, you can go to the next slide, our guidance on multi-month, we also recognize that multi-month does require an initial bolus of stock, especially when you're doing it in mass for patients, and that some countries haven't anticipated that and supplied their warehouses accordingly. And some do not have budgets for that. So we have begun to analyze what that financial addition would be. And we're hoping that we can secure funds for countries who are willing to go to 6 months, who could receive shipments. But that said, if supply to a particular country is to be bumped up in anticipation for 6 months, it may not be possible to receive that additional shipment until August through December. So I think there is going to be a tempering of the message on multi-month. PEPFAR did go out asking for 6 months and encouraging that, but I think as the guidance evolves just this week, we'll see a tempering to fewer months or 6 months with continual updating of stock information. And so we'll go ahead and jump into the decentralized drug distribution models that I know you're very familiar with, being part of the DSD network, but just highlighting a few key things that we're hearing from our colleagues around. We're seeing that the community and retail pharmacy model has been an important tool for allowing social distancing and scheduling of patient drug pickup, and allowing big hospitals and clinics to decongest, so patients don't have to queue for those pharmacies inside healthcare settings. Pop-up pharmacies have also been a good solution, but as some of the infrastructure is going to be harder and harder to obtain because of transport and border closures, this could easily be done through tents and fast lanes that are set up outside of hospitals that are large volume for ART clients. So we can go to the next slide. We're also hearing that a lot of countries are retooling their community adherence groups to include home delivery where that's permitted under lockdowns. And in other cases, they've found a way to secure third-party distributor home delivery. Some of the other measures, such as lockers and ATMs are probably not the right choice in terms of differentiated care at this point. Okay, we can go to the next slide. I did want to highlight some of the work that we've seen that we think is relevant in light of COVID to rapid deployment of these differentiated dispensing models. In Nigeria, they found a way to rapidly activate private pharmacies and community pharmacies by having a public sector health facility basically serve as a hub for logistics reporting. And so we have found that model to be very successful in terms of retention and viral suppression and client preference in terms of staying on through those programs, dispensing programs a year in. So we can go to the next slide. I'm sure many are familiar with South Africa's very large scale program for decentralized dispensing. It's just to say that these things rapidly. And in light of COVID, I would use as much as you can in terms of GIS locations and patient data to understand where you can provide mobile services or temporary services to do drug dispensing to decongest health facilities in the time of COVID. So we can go to the next slide. For those who haven't heard of this resource, I just wanted to highlight FHI put out a decentralized distribution of ARVs through the private sector strategy. They've really been leading in the USAID space in terms of gathering information. This publication contains a great landscape analysis and highlights some of the examples that I've spoken to in a lot more detail. We go to the next slide. So my recommendations in light of this guidance and in light of supply constraints would be that really as a clinical partner, as a Ministry of Health, you want to look to continually revisiting your plan for MMD and DDD and make sure that it's very intentional in light of stock orders. So each country generally updates its supply plan at least quarterly, but I recommend in light of COVID that be done more frequently, especially for the key drugs that are going to be given out multi-month. Excuse me. And consider the stock availability to have that. It's encouraging that we've seen a lot of circulars that have rapidly activated multi-month, but I think we do want to more issues. And of course, we do feel there's plenty of opportunity to scale DDD, but it hasn't necessarily been done intentionally in light of COVID and the planning we've seen. It's much more oriented around multi-month. So we'd encourage a plan that encompasses both approaches as differentiated models that could be useful for social distancing. So we also encourage practitioners in the field to look towards diagnostic tools. FHI has developed a rapid diagnostic tool for MMD that can easily be conducted virtually. Understand what type of feedback needs to go into multi-month planning to improve it at a national scale, scale. We also would encourage the use of electronic data capture tools that are light touch, that allow for a more constant feedback loop between the clinical setting and the supply chain practitioners at the central level. So I want to thank you all for your time. Feel free to reach out to me with questions. I work with a whole team of cross-sectional practitioners that work in the clinical space, supply chain, to answer any questions. Thank you.
Great. Thank you so much, Kelly. And again, a big thanks for doing a rapid summary in a short period of time. We will be sharing all the slides. If you have questions, you can put in the chat box. But I did want to call on Jessica Burry from the MSF Access Campaign. Jessica, just to see if you have anything to add or any other perspective or information.
Sure, thanks. So I don't have slides prepared, but I did jot down a few notes. And I agree with a lot of what's been said in terms of the unknowns. And at this point, we don't pan out, whether it's in India or China, but also in all the countries where we're living and working. and how that impacts things like logistics and, you know, drivers who need to bring orders to ports, or customs officials who need to go to work to process paperwork for imports and exports, for example. So we see that despite shutdown in India, there's some effort that pharmaceutical manufacturing and transportation should continue. But there's a new normal, and they're adapting. And so we are seeing varying reports of what that means across the different companies and states, and still really, yeah, having to be conscious of potential delays, and again, seeing what happens next week and how much longer this might continue in India, but also in every other country where you might also see some delays in terms of transport and customs processing of oil coming into countries. So what I would say is that we really do look country by country, knowing the amount of stock available in a country, and if a supply chain has already adapted their stocks and their pipeline orders and their warehouse have a sufficient supply for 3 or 6 months, if going to an MMD type scenario. I think there are alternatives that were already discussed that are perhaps more interesting, or a safe bet in some ways, in terms of giving people options around like community groups, and having alternatives basically give 3 or 6 months supply in the cases of countries that aren't ready yet to transition. So the idea is to avoid artificial shortages. If we give 6 months supply to everybody right away, then what will happen in a few months' time? So we do need to avoid those artificial shortages, use different models and distribution models where, you know, one person can pick up a month's supply of ARVs for multiple people who live in the same area. And I think that's nothing new. It's just a matter of making sure that it's implemented. And in that way, we still, you know, maintain social or physical distancing. We still reduce the number of people coming to the clinics and the hospitals to avoid exposure to COVID, but without too much constraint on our supply systems, and to try not to put that too much jeopardy when we do have a variant. I think probably it also sort of depends on different ARVs. It can also be product specific. So, you know, our first line, tenofovir, lamivudine, dolutegravir, there's plenty of global supply. It might be easier to get that one moving than some of the others where we see, you know, smaller amounts of ARV being produced. Last point that I want to make, that ARV Procurement Working Group, which is a global, a group of global stakeholders, including PEPFAR, Global Fund. There's also some governments represented there, including South Africa and Kenya. And I'll put the link for that that group in the chat. A good resource to see what, you know, their advice might be in managing different situations and different scenarios. And I'll stop there, but happy to have discussion later with everyone else in question.
Great, thank you so much. So yes, that a great perspective. I think this is, as you both have stressed, a really fast-moving situation, and yet ministries of health and implementers and health facilities are having to make decisions about dispensing and prescribing in the absence of good information. So I think you know, this type of exchange, this type of really real-time answer is invaluable. So thank you to both of you. We are going to share Stella Cantuzzi's slides. And Stella, I see you online. Are you able to hear us? And would you like to present, or would you like me to present? Stella's having
Ella, I think you can go on and present.
Okay, well, with humility, now I'm really self-conscious that Stella is with us. I'm going to present her slides because of her connectivity challenges, and then maybe Stella, you can comment and say if I've done anything incorrect. But we are delighted both to have this and the in-person presence of Stella Cantuzzi, who is the executive director of Nafafana Uganda, which is the umbrella organization of sorts of people living with HIV. And we asked her to give the perspective of recipients of care on issues related to accessing care and multi-month dispensing. So she notes that before the COVID-19 pandemic hit, the Uganda Ministry of Health had drafted a policy to support 6-MMD, which was pending dissemination. And with the onset of COVID-19, people living with HIV have been affected in many ways, including in terms of their access to ART and longer refills. And so in the context of leading the National Forum of People Living with HIV/AIDS networks in Uganda, which is in 123 districts throughout the country, Stella was able to do quick level at the community level. And so unsurprisingly, the regions and districts are affected differently. It's very context specific. But in general, there were some observations. So Uganda has a very vibrant, mature DSD sort of portfolio of models. And that includes the community drug distribution, community client-led ART delivery models. And the impression from Stella's group was that these were working well, and that in some cases new groups have been formed to care and treatment to more to the community level. Importantly, while many ART facilities remain open, people are still mostly getting refills ranging from 1 to 3 months. The informants noted that several health facilities and implementing partners have really gone the extra mile, including home deliveries. And that in addition, people living with HIV, not necessarily the trained group leaders, but a wide range of people are delivering ART and other supplies to their peers. And that the Ministry of Health has provided guidelines to ensure uninterrupted comprehensive services. And so that includes ART supply during a lockdown, even for people who may be accessing a health center that's not their usual health center. And I'm sure that we can get them to share those guidelines as needed. So there were some gaps. So given the lockdowns, that has exacerbated issues about long distances to refill centers, exacerbated challenges with transportations. In addition, some facilities don't give ARTs or only give a small amount of ART refills to people who are new to them, whether or not they're new to ART. There's the observation, which is true throughout the world, that there is no or limited personal protective equipment, either for health workers or for the peer educators at health facilities. There were concerns about stockout in several districts. Unsurprisingly, several facilities are closed or staff aren't able to get there. And there are really important issues around hunger and stigma, and concerns about sort of rumors that ART might be used to treat COVID-19. I don't think there's data for lopinavir specifically, but that this concerns could worsen stockouts. So critical issues that Stella wanted to highlight were, again, sort of supply chain, the issue of drug stockouts, issues around the sort of multi-sectoral issues around concerns about intermittent treatment leading to drug resistance or unsuppressed viral load, worsening illness and mortality. Really a huge challenge. And the Stella and Nafafano are urging implementers and planners to think about both biomedical and behavioral and structural interventions. So thinking about integrating the response to COVID-19 or considering serious ongoing conditions as part of the COVID-19 response, close attention to supply chains and support to the existing structures of people living with HIV to mitigate the impact on their access to treatment. And so community system strengthening becomes paramount. We would argue it's always paramount, but even more paramount. So thank you very much to Stella for those slides. And I'm first going to add anything, or if I misrepresented anything. Stella, if you want, so you're muted now, but if you wanted to add anything in the chat box, please feel free. While you're doing that, I wanted to just ask a couple of other people to comment on the recipients of care and people living with HIV. So I see Lillian Wareko. I didn't warn you, but well, I sort of warned you. But if you can unmute, if you wanted to, if there's anything that you might want to add. Laura, if you could unmute Lillian.
Hi. Thank you so much, Miriam. Cut across the entire Uganda, and I know my colleagues are on. They can actually for sharing this presentation.
Thank you, Stella. And Lillian, any additional reflections?
Hi, Lillian. Yeah, the presentation has been elaborate and speaks to everything. I just wanted to add that I think one of the outcomes of what we are going through, what we are seeing is the strong collaboration and partnership that has come out between recipients of care and implementing partners, that we are all working together to ensure that service delivery does not get interrupted. So I think that other countries can also learn from. But I also wanted to speak to the aspect of how we are learning from the world of HIV to inform and influence what happens within the COVID-19 world, that we are trying as much as we can to share knowledge and experiences where we are seeing human rights violations coming out. So I think another point that we could all learn from as we look at service delivery, as we look at everything, is to see how do we use the knowledge that we have, how do we use the resources to share with communities awareness and reduce episodes of stigma and discrimination and also human rights violation. Yeah, because one of the things that at least we are not that the community, it is this time that everybody in the community has been impacted by COVID-19, and some people have never understood what stigma and discrimination means, but it's within this delivery we have an opportunity to share all those resources and to work towards ensuring that we reduce as much as we can stigma and discrimination levels in order to make sure that we are able to prevent COVID-19. Over.
Great, thank you so much, Lillian. That is a great point. I am going to move to our next presentation, but do please, if people want to add perspectives in the chat, we'll do that. We can share this along with any comments that you want to add along with the slides. I am very pleased to introduce Murti Getachew, who is the HIV team leader from the Ministry of Health of Ethiopia. And she's going to provide an update on Ethiopia's response to COVID-19. Murti, remember to say next slide because Laura is projecting.
Good afternoon, everyone. Thank you for the opportunity to share the updates. Our presentation mainly focus how to maintain the continuity of HIV services for failed HIV in the context of COVID-19 outbreak in Ethiopia. Next slide. Hello? Yeah. The response is to maintain HIV care and treatment service and to prevent or mitigate the COVID-19 outbreak. So COVID-19, as you know, COVID-19 will substantially affect fragile health systems and community affected by HIV. So Ministry of Health to uphold that prevention and rapid containment of a priority in order to reduce the impact on the provision of need to services for people HIV, and it is practice to have plans to ensure the, sorry, next slide. So due to COVID-19, the anticipated challenges will be the first one, disruption of critical supply chain, shortage of drugs like ARV and other commodities. And the other anticipated challenge is shortage of personal protective equipment, and HIV patients will at increased risk of exposure to COVID-19 during health facility visit for follow-up, and disruption of HIV testing care and service also the anticipated challenge, and shortage of healthcare workers and shortage of transportation also the anticipated challenge in case of COVID-19. And overwhelming medical facilities also the other challenge, and inadequate awareness, unnecessary rumor in the community also the challenge, and the other challenge is misuse of certain ARV also the anticipated challenge. So next slide. So to tackle the anticipated challenges, Ministry of Health has prepared a guidance to standardize national response to control the spread of COVID-19 among people living with HIV and healthcare workers, and to mitigate potential consequences of COVID-19 pandemic. The response mainly focus to maintain support to individual vulnerability while minimizing their risk of exposure to COVID-19, and to contain and mitigate the spread of COVID-19 in the community affected by HIV. So properly triage and isolate patients seeking care for acute respiratory illness, and minimize exposure of both ART and staff to patients with COVID-19 is the main focus of the guidance. Next slide. So the guidance develop activities. The activity will be undertaken at different levels, starting from Ministry of Health, national level, regional level, district level, and health facility level. So at the Ministry of Health, the Ministry of Health provide policy guidance on role and responsibility for all levels of the health care system, and actors in minimizing the delivery of, in maintaining the delivery of sustainable quality HIV service in context of COVID-19. And also the Ministry of Health also develop and disseminate contextual messages prevent acquiring of COVID-19, especially people living with HIV and healthcare workers. And also issue guidance, flexible working hours, and virtual service delivery. And also the Ministry of Health also issue guidance on daily service availability, and submit orders for all commodities 1 month earlier than typical lead time worldwide suggested. Next slide. So at IPSA level, or Ethiopian Pharmaceutical Supply Agency will go closely, we are working together. So IPSA will monitor and analyze the existing stock status, all HIV-related commodities, and speed up the distribution to respective facilities. And also IPSA speed up all order on pipeline and delivery through all means. Also, IPSA also ensures supply of commodities both for treatment and infection prevention interventions, initiate emergency procurement order for any possible gaps that may arise, and also ensure all pharmaceutical supply agency hubs are closely working with the regional health bureaus and health facility for enhanced response to related requests. Next slide. So at IFSA level, task force established to work on stock status of the ARVs and other HIV commodities. So the task force will follow the status and update the higher officials. At regional level, regional health bureaus should cascade the guidance. Nationally prepared guidance should cascade at lower level and follow the implementation at all facilities and community setups. And also, regional health bureau mandated to disseminate of contextual message on prevention in collaboration with the national task force, and also work closely with the pharmaceutical supply agency hubs to ensure the adequate supply of HIV commodities, including ARVs and other at health facility levels. Ensure daily service availability at all facilities. So regional health bureau should have follow and monitor those activities at lower level. At facility, next slide. At facility level, facilities strengthen existing DSD model and implement new DSD models. Provide 6 months multi-month dispensing for all eligible stable clients for appointment spacing model as per the guideline. We have 657 coverage of appointment spacing, so the other 43% should enrolled in appointment spacing model. The other activities provide 3 months multi-month dispensing for non-eligible clients like PMCT, pediatrics, newly identified HIV positive clients, clients on second line ART, and unstable clients with high viral load and on enhanced adherence counseling that does not seek admission should enroll in 3 months dispensing. And also facilities provide fast-track ART refill model and community adherence groups for eligible patients, and consider family-based refill in which those with other comorbidities and age above 60 years can delegate others to collect the ARV on their behalf. Flexible service delivery model and client-centered service like early monitoring, weekends, and lunch time to reduce congestion in facility, and spacing of waiting seats and clinics should be provided by the health facilities. Next slide. And facilities also ensure all clients are given the health facility phone number. The ART clinic phone number should be clearly displayed so that clients can easily contact the health facility. And also all clients and the ART providers who develop respiratory systems like flu-like symptom should follow the emerged guidance for seeking care. And if a client or healthcare provider with suspect, probable, or confirmed COVID-19 has to come to the health facility. Next slide. Triage any client or healthcare providers who are unwell or flu-like respiratory symptoms seen first, and provide them with a face mask and immediately upon arrival. All ART providers who are unwell or should take sick leave and stay at home. And ELT provider can and clients should practice frequent hand hygiene. Its provider should use the necessary personal protective equipment. Next slide. So at the ministry level, ensure program monitoring and supply chain management in the context of COVID-19. So MOH understand contingency planning and prioritization are needed for all aspects of the HIV program in the context of anticipated disruption. And also MOH intends therefore to develop a plan for routine monitoring of the program and communication with regional bureaus and implementing partners in face of service disruption. And also we are closely monitor the recommendation in supply chain management and will confirm to the global recommendation. And also the ministry will track the appropriate use of the reviews as per the national guidelines. So the Ministry of Health will follow the activities and other issues regarding to COVID-19. So those are the main focus of my presentation. If you have questions or suggestions, that's welcome. Thank you so much.
Great. Thank you very much. And I'm sure that we'll be reaching out for piece of some of the guidelines. It sounds like Ethiopia, as many of the partner countries has really developed a rapid detailed guidance. So thank you. I wanted to point out our time is a bit short. We're going to be moving to our last presenter in just a moment. And Laura, if you could pull up his, that would be great. I did want to point out in the chat box, Katie Godfrey from PEPFAR noted that PEPFAR will be issuing revised guidance tomorrow. They've been updating their guidance thrice weekly. One is due tomorrow. And she says, we are recommending, as has been discussed here, a careful assessment of national stocks with early refills. We're aware that pediatric formulations are particularly problematic. So stay tuned for that. We'll also share that. Laura, can you pull up Josen's? Oh, looks like you beat me to it. Okay, great. So with apologies, Josen was bumped last week because of time. So we're giving him the full 7 minutes remaining in our hour, and thank him for his gracious patience with this. So Josen Kagunda is the National Technical Advisor for DSD at the Ministry of Health of Uganda. Over to you, Josen.
Thank you, Miriam, and good evening all. Can you hear me?
Yes, loud and clear.
So I'm going to share on what we have been able to do in the current period of COVID-19. The next slide. I'll look at highlights in Uganda, steps taken to control and manage the epidemic, and then DSD in the context of COVID-19, and some materials to share. The next slide. Uganda currently has a total of 52 confirmed cases with 0 deaths and none reported as recovered. The first case was confirmed on the 20th of March, 2020, and all the 52 are in stable condition in the various treatment centers. Cumulatively, we have tested 3,160 individuals under institution quarantine, 657. Contacts to confirmed cases who are being followed up, 855. Next. I just wanted to share the trends of confirmed cases. They don't have much to say, but you see that from the 20th to the 6th, those have been the reported cases, with our first case being on the 1st, and the most recent cases confirmed were 4 on April 5th April. 6th, we didn't have any cases, though we had some tested. And that map just gives a representation of the distribution of confirmed cases by places of residence. It does not mean that's where they are, currently because some have already been moved to the treatment centers. The next. So what steps have been taken? At national level, a task force was established, and these developed communication materials and case management guidelines relating to the management of the COVID-19. Presidential directives were given, one of them being the shutdown of all transport, public and private, exception of the essential institutions like health, security, and banks and the like. Closure of most of the businesses, with the exception of food markets, supermarkets, and pharmacies, and exempted businesses who are required to ensure they provide accommodation within the premises or at least nearby. All gatherings of more than 5 people were prohibited. In addition, a curfew has been put in place. No movement between 7 p.m. Up to 6 a.m. in the morning. At the AIDS control program, Ministry of Health, a task force was established, and this was intended to provide guidance on infection prevention and control within the HIV service delivery. A circular was sent out, and this SCP organized several calls with the stakeholders to discuss its implementation and various guidance provided. And a team within the task force was also established to ensure they coordinate at service delivery during this epidemic. And myself, the program officer in charge of DSD, is among those people coordinating to ensure that whoever requires HIV services actually accesses them amidst the lockdown. The next slide. DSD. AIDS control program task force was formed aimed at reducing crowding of clients at delivery points, but also ensure continued access of during the pandemic. And amongst these guidance, one was the recommendation of the multi-month dispensing, ranging 3 to 6 months. We agreed that the community distribution of ARVs needed to continue at our community drug distribution points and our community-led at deliveries. However, guidance was clearly provided to ensure that infection prevention and control measures are maintained at all those points. And then clients far from their usual facilities, we noted that some clients actually were found either far from their facilities or naturally their facilities are far from where they reside and therefore needed support. So we gave guidance that clients could access care ARV refills from their nearby facilities. And in this guidance, we further say that these are going to be given 1 month refills. We have provided guidance on how do we document those we are considering visitors, or how to document when they go to their nearby facilities, reporting and follow-up guidance. All that has been developed. The next slide, please. We also know that there are specifics where we are still recommending that monthly refills are provided. And this includes the very sick. The very sick, you give those who are under TB treatment in their first intensive phase, the pregnant mothers, the lactating mothers with babies below 6 months, the visitors or the walk-ins, those who are going to their nearby facilities, all those are getting 1 month refill. Due to stock challenges across the country, we are recommending that all recipients of care on second and third line are going to be provided monthly refills until the stock status changes. We have suspended all facility-based groups, which include the family support groups targeting the pregnant and lactating mothers, the adolescent groups, and then the teen clubs. Guidance will be provided when these can be reopened. We have engaged, and I was happy to hear Stella and Lillian speak to this. We have engaged the people living with HIV networks, and there's active support to actually provide delivery services to their peers. The next slide, please. Supply chain modifications. It is known that there are going to be some challenges. So as a program, we have liaised with the national warehouses to deliver 2 cycles at the same time. And this is to support the anticipated false consumption because of the multi-month deliveries. And that the warehouses are actually implementing. We have also worked with the implementing partners to innovate delivery of ARVs to the recipients of care, with some implementing partners doing door-to-door using either motorcycles, but also setting up community drug distribution points that were not existing prior to the COVID-19, but have been deemed necessary, and implementing partners are supporting that. We have worked with networks of people living with HIV to support at delivery to those who are unable to access them. We also are observing supply chain challenges, one of them being the limited stock of second and third line supplies. Our supply chain team is working to ensure this gets resolved, but for now, that stands out as one of the key challenges. We have provided a documentation guidance, but this still stays documenting and reporting ARV consumed by the visitors. The visitors, these are who are walk-ins, not just at the parent facility. We are having challenges for the visitors actually going to various facilities and getting several refills, which we are calling double dipping, and that is actually something that can severely affect our stock status. The next slide. So these some of the materials that we believe we can share with the network. We have case management guidelines, we have communication materials, we also have infection prevention and control guidance for HIV service delivery within Uganda. Those are some of the materials we can share. The next slide. We want to acknowledge the National Task Force, the AIDS Control Task Force, the implementing partners, the district health team, health workers, recipients of care, other contributors who have actually supported us continue providing HIV services during the pandemic. Next. Thank you very much.
Thank you. So thank you, Joseph, and thank you everyone. We're past the hour. There was a lot of great commentary in the chat box, and we will follow up with answers to people who have specific questions. We'll connect you to the questioner. We're going to share the recording of the webinar and the slides on the CQUIN website. I also put that in the Dropbox. And we are going to continue related adaptations to facility-based models. And the week after, we're going to focus on adaptations to community-based models. But anyone who isn't in the WhatsApp group and wants to be can contact us, and we'll add you to that, because I think there's going to be lots of discussion between now and
Thank you so much. Thank you.